One. Hi, I'm Frank Diamond, the managing editor of Infection Control Today. With me today is Dr. Brent James, an internationally known expert on clinical quality and patient safety. Dr. James is a clinical professor at the Clinical Excellence Research Center, Department of Medicine, Stanford University School of Medicine. He is also a senior fellow at the not-for-profit Institute for Healthcare Improvement in Boston and a senior advisor for Health Catalyst in Salt Lake City, Utah. Dr. James is at one time the Chief Quality Officer and Executive Director of the Institute for Healthcare Delivery Research at Intermountain Healthcare. He knows about both the provider and the health plan side of healthcare, in other words. Dr. James, let's begin by talking about health insurers and infection prevention. You would think that infection prevention would be a provider problem for the most part. It happens for the most part in hospitals, and doctors and nurses are the ones that have to deal with it for the most part. What kind of, to coin a phrase, skin in the game do health insurers have now with in terms of infection prevention?
Well, you're absolutely correct, Frank. The real action happens on the clinical side, down where clinicians are taking care of patients. As you might expect, as soon as you get a health plan involved, it's all about the money. Turns out that when you reduce infection rates, nearly always it reduces the cost of health care. It takes an investment to make that happen, though. Quality is not free. It takes a change, nearly always on the clinical side. The question is, who gets the savings? Depends on how you're paid. If you're paid fee for service, all of the savings go back to purchasers, to insurers, as kind of these just, unearned benefits, if you will. They might argue that it's something we should be doing anyway, which we should. On the other hand, you need something to offset the investment and hopefully maybe a little bit of upside for investing in the next project. So it all depends on payment mechanisms.
It all depends on payment mechanisms, meaning does there have to be a change in payment mechanisms for insurers to get more actively involved in infection prevention?
Yeah, the real role, and I see it happening in a number of places across the country, it's the difference between fee for service, which is kind of at the base level, moving up to per case payment, DRGs mostly, up to some sort of provider at risk. There are at least 7 or 8 different versions of it. The extreme is full capitation. And what that determines is who gets the savings, you see. So imagine that I run a truly outstanding infection control program. My infection rates drop dramatically. It means we don't have to pay to treat the infections. Nearly always it has a huge return on investment. Serious money coming out of that thing. If I'm paid fee for service, all of the savings goes back to the insurance. Believe it or not, there have been fewer cases in Korea with a population of 30, 40 million people than there have been in Utah with 3.1 million people. But the reason is the Korean government was on the alert, watching for it. I bet next time, well, I don't know. I was going to say next time, I bet we don't get caught so badly as a country, but give it 20 years, 30 years, let a new crew come into political power, right? Who've forgotten what it was like. Who knew not Pharaoh.
You really think we're not going to learn permanent lessons from this? This is a world-shaking catastrophe. They're comparing, as you know, they're comparing it to World War II and the Great Depression, not the 9/11 and the 2008 meltdown. They're really saying this is a huge thing.
You'd sure hope so, wouldn't you? Now, the other thing that needs to be said about COVID, Frank, is this. I have a colleague that I deeply, deeply respect at Stanford, John Ioannidis. His real specialty over the years has been the philosophy of science and clinical research and how we know what we know. He's one of the real experts on the evidence base. He's been criticizing us legitimately, fairly, that given the way that our research infrastructure works, we reach conclusions that are not defensible. They're non-replicable. We can't reproduce them in a secondary way. John's been making a very important point, and I agree with him. It's that statistics background. The best little microcosm we have of COVID is that cruise ship, that Princess cruise ship, where probably everybody aboard the ship was exposed. And it gives us an early first estimate of, given full exposure, of symptom appearance rates, of significant disease rates, of ICU admission rates and mortality rates. One of the problems you've had is a number of different groups making models of how bad COVID is. And John points out, I believe correctly, he raises a flag. He says, many of those models are not accurate. They're in the extreme. I personally believe that when all the data come in, that it's not going to be quite as catastrophic as most people believe. It's probably better to overreact a little bit than underreact, especially when you're late to the game. Then you have to balance that against the fact that, we're tanking the economy. So a couple of interesting statistics you might find useful. The number of people appearing in emergency departments is down significantly. At least here in Utah, it's down 30 to 50%. People just aren't coming in for fear of exposure in a hospital setting. Some EDs are turning people away if they don't have very acute symptoms, especially COVID-related symptoms. What we know is that regular medicine hasn't disappeared. People are still having heart attacks. They're still having strokes. They're still having significant acute needs. In the past, we would have hospitalized and helped. So we know that the rates are down of caring for those directly. The other thing we know, I was talking to a colleague who runs one of the largest private health systems in the US. They have a whole bunch of EMS, emergency medical services, running. He tells me that the proportion of cases where the EMS team arrives at a person's home only to find the patient dead, already deceased or so close to deceased that they can't intervene effectively, is up about 30%. John at Stanford, John Ioannidis, points out that that the rate of mortality in the young, so COVID is mostly a disease of old people like me, right? With compromised immune systems, not like me. That's where most of the deaths are occurring. The suicide rate in the young is dramatically larger than any estimated COVID mortality rate in people who are fairly young and healthy. And almost certainly what we're doing to the economy is going to increase the suicide rate. I just read a statistic from World Health Organization that the number of people who are facing imminent starvation is going to bump from about 130 million people worldwide to about 265 million people worldwide. It all settles around our ability to test. So better identify who actually is actively carrying the disease and better identify those who are carrying antibodies who've been exposed. So the estimates of the proportion of people who have basically caught COVID and had no symptoms are all over the map. The lowest I've heard is about 1 in 3 people who get COVID have symptoms. There are 3 studies, by the way, one in New York, one in Los Angeles, one in Santa Clara County, California, that suggest that it might be only 1 in 40 to 1 in 50 people who get COVID have any detectable symptoms. We don't know that number. And until we know that number, our ability to model what's going to happen with it is very seriously compromised. You see, now you could argue it's better to be a little bit more conservative relative to a nasty thing like this than a little too liberal, right? You'd rather err on the side of being more protective, and I get that. I kind of agree with it, actually. But holy cow, we need those numbers. That would make such a big difference in our ability to respond. Of course, that does not justify the fact that we were caught absolutely flat-footed. It's a leadership issue.
And you mentioned earlier the suicide rate. That's of despair, as they call it. It's been on the rise even before this has happened. And I think you and I are having a conversation that a lot of people are having across the country. And I've had it even with my own friends. When a society goes to war, if it decides to go to war, it has to weigh, well, how many people are we willing to sacrifice to achieve the aims that we want to achieve in this war?
Yeah.
And as we know, there's wars of all kinds. There are justifiable wars when you have to fight a war of defense, such as happened in 1939 against something that was truly evil. But a society has to weigh that.
Yeah.
So when I say that to some people, they say, well, the problem is that we don't know what the risk is. If we can say with certainty that if we get everything back to normal again, we might lose 1 million people. as heartbreaking and as horrible as that might be, we could weigh that risk against the risk of totally tanking the economy, throwing a lot of people into not only economic poverty but healthcare poverty, because you lose your job, you lose your healthcare benefits, and
Yeah.
what's going to happen with those people? So I think that's kind of, but we just don't know, and I think that's the thing that's holding us up.
You're absolutely correct, Frank. You nailed it. It's making good decisions in the face of poor information, and then being able to adapt quickly along the way. The one thing we do know is if we had better, more reliable testing, that it would be a wonderful aid. And of course, we're really pursuing that vigorously right now. And I anticipate there'll be a lot of give and take, a lot of different conversations. But I think over the next month or so, our testing rates will really come up. Our strategies for controlling spread of COVID will really come up. We'll get a much better picture. Again, looking back, we'll have a much better view, and then we'll probably be fairly critical of the people who are trying to make the decisions at this point in time with poor information. That's just typical human beings. It'll probably be a little bit unfair. The only real hope is, will we be ready next time? Will we have a better handle on it next time? That extra month and a half, 2 months, wow, that would have been useful if we'd been out in front of this.
What testing have been available? I mean, could you stockpile tests for COVID-19, or basically you have to figure out what it is first and then develop a test for it, right?
Yeah, 2 kinds of testing that we really need. One is to detect active current disease. The other is to detect antibody levels, to give us a better sense of how it spreads and how fast it spreads and the consequences of it. So that's sort of testing coming online. What happened at the start of the epidemic is that there was some missteps between the FDA, which has to approve the tests. They were running a typical regulatory state with fairly tight controls. There are good reasons for that, to protect the public health. They probably should have relaxed those much earlier. CDC was trying to concentrate and devise their own tests as opposed to relying upon a massive reservoir of scientific knowledge and ability out in private industry. The pathologists all around this country who build those tests, you see. And we needed a better, faster response to that. That's when I say we lost about 6 weeks. That's what it was.
Right.
It's this dance between CDC and the FDA as they tried to move up onto a war footing, if you will. And they were a little slow getting there. Now, in truth, I wasn't entirely surprised. I believe it's hard for regulatory agencies to make that shift that quickly.
Right.
In all fairness, good people, by the way, not a matter of bad people, good people working hard. It was seeing it early enough that you could start the response fast. Now, in truth, I personally think the Chinese did not serve us well in terms of how they handled information about this. They were a relatively closed society in that regard, and I don't think that they were as transparent as we would have been, for example, any Western society would have been. And that was one of the causes of the delay, and it's a legitimate criticism, to my mind, that they weren't as open about it as they might have been. But we weren't as open to hearing it or responding to it quickly, you see. And so,
Dr. Brent James, thank you so much for being with Infection Control today. Any final thoughts about COVID-19 or health insurers' involvement in infection prevention in the future?
well, Frank, the one thing I will say, the thing that I really hoped we'd get to and we didn't, our ability to control infections in routine healthcare delivery is improving dramatically. Many places around the country really haven't made it happen yet. That's the real opportunity right there. That's where infection control professionals can really make a difference. That would be another conversation, but that's a huge opportunity in the long haul. This will play out a lot longer than COVID does, you see. And that's a conversation worth having.
Well, let's just take advice from the doctor, the good Dr. Brent James. Thank you so much for being with Infection Control today, Dr. James.
Thank you, Frank. Sure appreciate the conversation.